Good morning. My name is George Nearsu. I'm the MLA for the Mackenzie Delta and Deputy Chair of this committee. This meeting is being live streamed on the Assembly's social media channels. To keep the meeting running smoothly, please wait to be recognized and for your mic to be turned on before speaking. And please direct all comments and questions through the chair. I will now ask members to introduce themselves, starting on my left.
Thank you, Mr. Chair. Good morning. Welcome to committee this morning. My name is Danny McNeely and I represent the Sahtu region.
Good morning. I'm Shauna Morgan, MLA for Yellowknife North.
Those online, Mr. Kieran and Ms. Whelan Armstrong, can you introduce yourselves, please?
Yes, good morning. My name is Kieran Testart. I'm the member for Range Lake. I apologize for not being there in person. I had some unexpected childcare requirements that I had to attend to today, so I will be attending remotely, obviously, but looking forward to the presentation.
Jane Whelan Armstrong, MLA for Mofi, Clutha Region.
Thank you. This morning, committee welcomes Megan Wood, Chief Executive Officer and Registrar at the College and Association of Nurses of the Northwest Territories, and Nunavut will deliver a briefing on healthcare sustainability in the Northwest Territories. Thank you for joining us. I'll turn things over to you for your presentation before taking questions from MLAs. Please go ahead.
Thank you, Mr. Chair, and thank you for having us here today to discuss healthcare sustainability in the Northwest Territories. As you stated, my name is Megan Wood. I'm the CEO and the Registrar at the College and Association of Nurses of the Northwest Territories and Nunavut, and with me today I have brought our Deputy Registrar, Amélie Duval. So a little bit of a brief background. We've been in existence since 1975, when we've served as both the regulator and the Association of Nurses for the Northwest Territories and Nunavut. And then in 2023, we began regulating licensed practical nurses and registered psychiatric nurses, in addition to registered nurses and nurse practitioners, all of whom fall under the Nurse Practitioners or the Nursing Professions Act. So at this moment in time, we are a dual mandate to protect the public and advocate for the nursing profession, but in this coming January, we'll be divesting our mandate of advocacy for the profession. And so with that, we'll be following with the incorporation of the Northwest Territories and Nunavut Association of Nurses, the NTNAN, and that body will be responsible for advocacy of the profession. At this time, NTNAN has a new board of directors and a new executive director who has recently been hired. And once we have completed incorporating, they will be funded for a 2-year period through our organization. And that will give us the time and space to really focus on our regulatory functions. So a little bit about what we're doing right now to update or to uphold our mandate of public protection. We have 3 core divisions at CAN: registration and licensure of nurses that want to work in the territories, quality and practice and continuing competency of the profession to ensure that our professionals are working and engaging in lifelong learning, and oversight of professional conduct. So our work is really focused on the delivery of safe nursing practice in the Northwest Territories and Nunavut. Some of the things that we've been working on that have been priority as of late are interjurisdictional nursing licensure and labor mobility. And we've been working with the other 21 nursing regulators across Canada to facilitate a common approach to the licensing process. The intent being that nurses who want to be mobile between different jurisdictions are able to move between provinces and territories without there being lengthy waits. Some of the ways that we've been actually implementing this, though, is through changes in our license type upon renewal. So in October of this year, we implemented home versus host jurisdictions for nurses that want to work in the North. And this means that if a nurse has a primary regulator in a southern jurisdiction, then they're exempt from our continuing competency program and our audit processes. To ensure that we're still upholding quality public protection and that nurses are engaged in lifelong learning, every regulator that sits at the national table has guaranteed that they will continue to enforce continuing competency of nurses in their jurisdictions. We've also made a commitment to process verifications in less than 10 business days. So as regulators, we need to ensure that nurses coming from other provinces or territories do not have a history of misconduct in those areas. And the current process for doing so is through verification. But in January or February, depending on timelines, we will have onboarded the Nurses platform. And Nurses is going to be a national database that assigns a unique identifier to each nurse in Canada's healthcare system. This will reduce the ability for nurses to jurisdiction hop from space to space, and it will prevent name changes. And so this will significantly increase our processing times and allow for streamlined tracking of the profession. Another significant piece of work that we completed in 2024 was the expansion of the LPN scope of practice. Historically, the scope of practice for LPNs was very prescriptive, outlining the specific tasks that an LPN can execute. However, evidence has shown that prescriptive and limiting scopes of practice is not best for the profession of nursing. And so in collaboration with other jurisdictions, a scope of practice that is broad and speaks to each nurse's individual learned and gained competencies was implemented. The Nursing Profession Act also allows for 2 additional types of nurses: registered nurse authorized prescribers and registered psychiatric nurse authorized prescribers. And right now we don't have any of those licensure types active in the territories, but we are in the process of a jurisdictional scan to understand how other jurisdictions have implemented this type of licensure and the requirements that they need to have to be able to diagnose, prescribe, and treat. So to achieve this, we have executed a nursing practice committee who are specifically tasked with exploring how this model of care is going to intersect with our current community health nurse model, which does have an expanded scope that best serves our communities. Internationally educated nurses, this has been a priority for CAN over the last year as well, and as this committee is aware, we've worked hard to create a pathway for licensure. We've contracted an assessment company, Inspire, who can complete an assessment for nurses who do not meet the minimum hour requirement, and which we reduced this year. This upholds the mandate of public safety, particularly recognizing that not all countries have equivalent nursing education to Canada. We also recognize, though, that there is a need for further research into other countries that do hold educational equivalencies, and so we're currently collating the evidence for other countries. We are also implementing a no-size-fits-all approach at CAN, so recognizing that we need to be agile and nimble in our applications. So if someone does not completely meet the criteria, they are still able to make an application to our registration committee, and we can consider them on a one-off basis. We also are currently undertaking a study in collaboration with the Institute of Circumpolar Health Research and Det'anchogh Incorporated to explore Indigenous students' experiences writing their licensing exams. We're very much in the early stages of this research, but we're hoping to understand why Indigenous members of our communities that have completed the Bachelor of Science or licensed practical nursing programs are having a hard time passing their exams. We recognize that there is a workforce that's out there, it's local, and it's not being utilized because of this barrier. So all this said, we've heard from registrants, we have been looking at data, and we've observed that there are actions that can be taken quickly to improve the healthcare sustainability of the Northwest Territories. One of the biggest, in CAN's opinion, is the fact that we have less than 5 registered psychiatric nurses practicing in the Northwest Territories. So RPNs, they're a highly specialized healthcare professional, and they provide holistic care to individuals and communities that's very focused on mental health and addictions. And if we can further utilize this profession and recruit these nurses to the territories, we can advance the territories' goals for mental wellness and addictions recovery. They are a highly sought-after profession, and they are highly utilized in southern jurisdictions and have been expanded into the eastern jurisdictions as well. We also see that with the increased LPN scope of practice, that there is room for this designation of nurses to grow. So we would recommend that employers review job descriptions for this designation. Employers are, at this time, providing skills and increasing autonomy for the profession, and I know that they're looking at how LPNs can be further implemented into community health models. But to successfully retain and recruit LPNs to the north, LPNs need to know that they're able to work to the ceiling of their scope of practice. Otherwise, we've heard from them time and time again that they will go elsewhere. As evidenced by this, one of the quotes that's on the screen right now is, "I feel right now that the RNs get all the glory and LPNs are left behind and treated unfairly." In all other parts of Canada, LPNs are given opportunities to work in various departments such as the ICU, ER, public health, dialysis, but that opportunity is not given to LPNs. Nurses come in many classifications, not just RNs. And I think that is something that should be echoed and we can really maximize on to deliver high-quality patient care. And along the same arguments for the increased utilization of LPNs and RPNs is the nurse practitioner, an autonomous profession that's proven to increase and improve patient outcomes, and while also being more cost efficient, it can increasingly, or it can significantly improve our healthcare system's abilities. I also wanted to touch on regulation of allied healthcare professionals. While we only regulate the nursing profession, there has long-standing been a perception that regulation is red tape or a barrier to professionals moving throughout the territory and being implemented into the workforce. But when executed correctly, regulation is not red tape. It's oversight that ensures that a profession is engaging in continuing competence and lifelong learning, that they're practicing safely, and it provides the public with an avenue to address concerns when they do have them. We receive significant inquiries from the public regarding other healthcare professionals, and we hear consistently that the public and the profession are eager for regulations that are anchored in right touch practices and smart delivery. So to increase the trust in the allied healthcare professions, having avenues to report concerns to a non-employer, or even the ability to look up a professional on a public directory increases the trust for the public. At CAN, we complete the approvals for all nursing education programs that are delivered in the Northwest Territories and Nunavut, and just recently Aurora College received their 5-year approval of the Bachelor of Science in Nursing program, and they also received a conditional approval on their licensed practical nurse program. And the reason that we do this is we want to make sure that we have a way of ensuring that our graduates from our northern programs are meeting the same standards and entry-level competencies as graduates across Canada. There are many other nursing education programs that would be beneficial to offer, and we hear quite often that nurses are going to southern jurisdictions to do online or bridging programs or re-entry to practice or their prescriptive authority certifications. And these are all really wonderful skills that we can bring to the north, but having to have students or nurses go to southern jurisdictions to gain this training is a detriment. And so funding for our educational programs and institutions to deliver and actually support nurses in getting this additional training would make a significant long-term impact on our health system. Lastly, we recently polled nurses about what would entice them to stay and work in the NWT and NU, and competitive compensation, as I'm sure is no surprise, was up there with the top. Also those staffing levels and nursing patient ratios, and work-life balance and improved housing. These were all some of the highest things that I think we've all heard and we've been told by nurses, but it is good to see that this is also validated in what we're hearing from our registrants. And here on this last slide is just some qualitative results from our survey. But to further validate this, and rather than me just reading these quotes from the screen, I thought I would share with you that last week I attended the Canadian Healthcare CEO Summit, and I met with the CEO of Health PEI, and she provided some really staggering statistics that they had actually increased their nursing workforce by 40% over the last year. And I asked how they did that. I was just very frank. I was like, please give me all your Coles notes. And as somebody that was born and raised on the island, I thought it was very interesting to hear that they leaned into the strengths of their province. They played into that lifestyle, into their geography, into the pros of living and working in their jurisdiction, but they also assisted in finding housing. So they didn't pay for the nurses' housing, but they did ensure that they had a place to stay and live whenever they moved to a remote or rural community on the island. And they improved compensation. They weren't able to match some of other jurisdictions given the size and the fiscal realities of their jurisdiction, but they did make it more attractive in that manner. So thank you for inviting us to be here today to present our work to date, some of the work to date, I should say, and our perspectives on how we can better deliver care to the Northerners. Thank you.
Thank you very much for your presentation. I'll open it up to committee members if they have any questions, starting with Mr. McNeely.
Thank you, Mr. Chair, and thanks for the presentation. This is I would say our health demand and needs and services is really close to my my wish list or my heart, I would say. I see a huge demand. I represent 5 small communities. One of the communities is a cabin community, and in today's society, I just see a huge need for social stability in all different levels. And if we don't have the people, our weakness is going to get larger. My good friend, colleague here from the Mackenzie Delta shared a spreadsheet with me several months ago on the medevacs for the Northwest Territories. So I focus on the Sahtu and took the numbers out, and I shared that with our leaders back home here to say you measure your society in different ways, whether it's the economy or the workforce. In this case, we had seen 448 medevacs in 3 years. So you do the math, it's shocking. Now, yes, I understand there's some elders that were part of those flights, but there was also a large portion that were forced by addictions. And the addictions could lead to a skidoo accident. I know of one. A skidoo accident happened a couple of springs ago. The victim was medevaced here. And there's a real high cost to that. Now, if we can use that, we can say, okay, maybe we should take some preventative actions. And let's see if we can reduce that from 448 to 200. Then we're measured by the success on what we're doing. So I look forward to following up in here. I just got to be excused. I got another appointment here from out of town constituent here at 11 o'clock to meet one of the ministers, so I'll be there. But I certainly will continue my support from my end. Thank you.
Thank you, Mr. Neely. Who's going to take, is there a question in there?
No, just an
Oh, okay. Okay, we'll go on to Ms. Morgan.
Thank you, Mr. Chair. And thank you for that presentation. There was a lot of sort of interesting and new updates to get, so that's super helpful. I wanted to zero in on the issue of integrating paramedics into our healthcare system. It's come up a number of times lately in our presentations from the minister and her staff. And in the last few years, NTHSSA has really been expanding already its use of paramedics, both in primary care settings in small communities, but also in emergency department settings at Stanton and Inuvik. And HSS has announced that it's going to be doing more research over the next few years on how to, more permanently integrate paramedics into our small community model of care in particular. So I wonder if you have any thoughts on how this might impact NWT nurses in either a positive or a negative way. Thank you, Mr. Chair.
Okay, thank you. We'll be taking the question.
Thank you, Mr. Chair.
I'm sorry, before we start, maybe just introduce yourself and your guest here.
Certainly. I'm Megan Wood. I'm the CEO and Registrar for CAN, and with me is the Deputy Registrar at CAN. And I think in answer to your question, there are both positive and negative impacts to nurses that come from this sort of model. One being is that there is workload relief, absolutely. When we integrate other healthcare professionals, allied healthcare professionals, it does alleviate some of the stress and high demand pieces of a nurse's role. And there's also the added benefit of enhanced team-based care. If we are able to have more of a team-based approach to the delivery of care in communities, there are proven positive health outcomes. What I would say is that it depends on if there's a stronger continuity of services, if this is successful or not. So we need to, a lot of the times we see communities that want to have individuals that are visiting their communities on a repeat basis. They don't want somebody that just comes in, provides short coverage, and then leaves. And I'm speaking quite general, but continuity of service delivery is something that could be a positive with this sort of model. But I think there are also risks to the nursing profession, particularly in terms of role substitution and delegation. So while the goal is to support nurses, those shortages can create pressure for paramedics to take on an increased scope of practice that they are not regulated to provide in the Northwest Territories. And also there could be system level impacts. So if we start filling nurse positions with paramedics, does that reduce our pressure and our priority of hiring more nurses into these roles to provide more fulsome care?
Okay, thank you, Ms. Wood. Ms. Morgan, do you have a follow-up?
Yes, thank you, Mr. Chair. So I think there is often some confusion about what is the difference between a paramedic and a nurse. And I mean, to be clear, HSS has said that it wants to integrate paramedics to support community health nurses, not to replace them. But at the same time, the reason we're utilizing so many paramedics lately is because of the shortage of nurses. So if we're short on nurses, can you just bring in a paramedic as like a substitute? Are they doing the same job? Or maybe you can explain what is the difference between what they can actually do. Thank you, Mr. Chair.
Thank you, Ms. Morgan. Ms. Wood?
Thank you, Mr. Chair. I'm not an expert on the scope of practice of paramedics. I am a registered nurse, and I can speak quite confidently to the scope of practice that nurses hold in communities. But one thing I would stress, I guess, is that paramedics and nurses are not interchangeable. That team-based approach to care is really what will make that model work. And so given the fact that paramedics do have a very distinct role that is very much trained for emergency response and protocol-driven interventions, means that we need nurses that are there to support in those interventions. And so they really have to work in tandem. The other thing I would mention with paramedics and oversight is that they are not regulated in territory. They are required to be licensed in another jurisdiction, but that doesn't mean that they have the same level of oversight that other professions do have. And so if a nurse is to delegate a task to a paramedic, they need to feel confident that that paramedic is able to do so within the scope of their individual practice. And without a regulatory body that's overseeing those paramedics' scope of practice on a consistent basis, nurses aren't going to feel confident doing that.
Okay, thank you, Ms. Wood. MLA Testart, do you have a question?
Yes, thank you, Mr. Chair, and thank you very much to sorry for the presentation. My question was about the LPN NNP scope of practice, and we've heard that the scope of practice was expanded to allow them to do more, which is a good thing, and I'm glad to see that they followed that kind of best practices advice of not being prescriptive and trusting LPNs in particular to do the job they need to do. But it is troubling to hear that people are still feeling frustrated that they're underutilized. So could you first give us a kind of a more depth to that understanding of why do LPNs and NPs feel like they're not being utilized well enough in the system? Thank you, Mr. Chair.
Thank you, Mr. Testart. Ms. Wood?
Thank you. I think a big part of this is the fact that the scope of practice needs to be supportive of the professions on many different levels. So we have the regulatory scope of practice, which is the legislative scope that a profession can work within. But then each individual professional has to also work within an employer scope of practice and their individual scope of practice. And so these things all start to intersect. If an employer's scope of practice says that an LPN can't do X, Y, and Z, but a regulator's scope of practice says it does, then that LPN can't very well go beyond their employer. And so until an employer updates a scope of practice or provides the training for them to work within that regulatory sphere of skills and abilities, they're not able to actually integrate it. And so I think that's part of where the frustration comes from, is that NTHSSA has been providing significant training and providing supports for LPNs to enhance their skills, but there's still further space and progress that can be made, particularly in the roles that LPNs can take on. in our community health centers and our acute centers as well.
Thank you, Ms. Wood. Mr. Testart, do you have a follow-up?
Yes, thank you, Mr. Chair. So just for absolute clarity, I guess the GWT is the employer, or the authority is the employer. They are operating a reduced scope of practice compared to what is possible by the professional scope of practice. Is that the disparity? Like, basically the GWT isn't operating LPNs, or allowing LPNs to operate at full scope of practice. Thank you.
Thank you, Mr. Testart. Ms. Wood?
I wouldn't blanket statements state that as the GNWT as an employer, because especially as we do have other employers such as Avens and other private contracted services. But I would say that the work around the job descriptions is being undertaken from what I've been told, and it's based on a per setting basis of looking at those job descriptions and updating them accordingly. So yes, making the job descriptions reflective of the regulatory scope of practice and ensuring that LPNs and nurse practitioners have the autonomy that they're able to execute on an individual basis.
Thank you, Ms. Wood. This time I'd like to welcome MLA Yakalaya. Does any, Ms. Whalen Armstrong or Ms. Yakalaya, do you have a question? I'll just fit one in the meantime. You made reference to your international educated nurses bringing our practice hours down from 1,125 to 450 hours. Has there been any improvements in recruiting nurses during these two-year period? And is it expected to go down any further, or is this your threshold for allowing nurses from other Canadian jurisdictions? Thank you, Ms. Wood.
One of the things that CAN is very proud of is the fact that we are agile and nimble, and that we are willing to make change where it is safe for the public to do so. And so our decrease in hours, it still remains 1125 in 5 years or 450 in 2. And the rationale behind that was that 450 hours in 2 years is a much more consolidated piece of practice than 1125 over 5 years, if you look at it in terms of 12-hour shifts. And so we have seen an increase in the amount of nurses that we've registered, especially IENs. There's some very happy stories about nurses that were working in jurisdictions like Alberta and Ontario that were trying to get 1125 hours, and they've since met the 450 and they've been able to come home. We haven't seen a huge influx in nurses doing the Inspire assessment. And I think that is where some of our surprise lies. We thought that, given that we had a lot of nurses that were working in alternate positions in the Northwest Territories, that we would have an influx of those nurses looking to have their education examined and their assessments and their competencies assessed. And that has not been the case. There's been quite a low uptake. And if I could defer to Deputy Registrar Amelie, could you let us know how many we have had go through that Inspire process at this time?
We've had...
Yes, can you just introduce yourself for the record, please, and proceed?
My name is Amélie Duval. I'm the Deputy Registrar at CAN. Since starting the Inspire, or partnering with the Inspire assessment program, we've had 2 applications who are still in the process of completing that assessment.
Okay, thank you. I'll just continue on. Going into your research for Indigenous nurse students experience writing in their license exam, what's your findings in this area? Are you finding the Indigenous population having problems with their writing these their exams, or is this throughout Canada, or mainly in Northwest Territories? How does the Northwest Territories compare to other jurisdictions in your findings with this research? Ms. Wood?
Thank you, Mr. Chair. This is very preliminary research and has very much been driven by the Nunavut Tungovik Incorporated, which it has seen and has anecdotal evidence of there being significant numbers of nurse graduates in communities that have not been able to pass this exam. Right now, we are in the data collection period of the study, which means we're reaching out to both of our licensure exam partners, NCLEX for registered nurses and CPNRE for LPNs. And we're hoping to be able to look at that data and determine actual numbers for nurses that have not passed the exams in our jurisdictions and the ethnicity of those nurses. And from there, we will partner with ICHR to start to complete focus groups. Whether or not we're going to keep this research focused in the NWT and Nunavut or expand it to other jurisdictions remains open to discussion. We're trying to decide where the value will come from in the research. Will it come from speaking only to Northern students, or will it come from speaking to students across Canada? Thank you.
Okay, thank you, Ms. Wood. Mr. Testart, we go over our second round.
Mr. Deputy Chair,
Armstrong,
it's
you're,
Jane here.
yeah, I didn't see, you didn't put your hand up, I didn't see it, so. Go ahead, Ms. Whalen Armstrong.
Yes, yes, we know that health is a major issue, especially for people living in the small communities, in the regions, in small communities. And I just want to, and then I see here that you did mention LPN, the scope of practice to do more. But living in small communities, due to limited resources, LPN, sometimes, a person can have a multiple role. So sometimes we have no control over some of these. So, and because they're unionized, and I just want to know or ask that if any of the small communities, because this is, we're talking about, I represent a small, 4 communities. So, and sometimes we do go without, and we do with what we have. So, so in that situation, so did, I know it's new, but in the past, did LPN play a larger role in small communities? Thank you.
Thank you, Ms. Whalen Armstrong. Ms. Wood?
Thank you. And if I'm understanding the question correctly, I think LPNs, the scope of practice is not a one-size-fits-all. The scope of practice depends on the setting and on the individual and the training that they have. And so in the past, LPNs may have been working in communities, but that doesn't mean that they are limited to a scope to that community per se. Instead, the scope has to be reflective of that individual, their training, and the resources that they have in place at that time and space. And please clarify if I've not answered your question. Thank you.
Okay, thank you, Ms. Wood. Ms. Whalen Armstrong, do you have a follow-up, or was there?
Yes. I do have a follow-up question, and thank you for questioning, for answering. Yes, I know that in many of the small communities, we don't have it's not just us in the Northwest Territories, it's across Canada where people are trying to hire and retain health professionals, especially the nurses. Even in the small communities, we don't even have a doctor. So a lot of our constituents, people living in a small community, they go to a larger regional center. So that's why we're in a situation where we started, in the NWT, paramedics, we started using paramedics in small communities. And with the model of care, they're going to introduce more. So I just, in small communities, I know people are used to seeing nurses, caring for the people, tending to the people, or, they're nurses, but they're not used to paramedics, especially in small communities, because everybody associate with the paramedics as an ambulance driver, So I know there are some apprehensive, some people are apprehensive about using the paramedics. So I just want to know if I want to know about how the people how I see you have the survey results, but I don't see anything about the paramedics. So how do people in a small community feel about using paramedics? Did we ever check with them? Did that department ever check with them? Thank you.
Thank you, Ms. Whalen Armstrong. Ms. Wood?
Thank you, Mr. Chair. I would not, I would be remiss to speak to how people feel about paramedics, given that that's not within our mandate or the work that we do in regulating the profession of nurses. But I would also, and I think I appreciate what you're saying. The fact that paramedics will be new to many of these communities is, and we've got people that are very used to seeing nurses, which are a very trusted profession. It does not mean that there is an opportunity for paramedics to have that same trust and that same level of teamwork and care working with nurses. And I think that really the key of trust and public safety is when paramedics and nurses work together to provide holistic, ongoing care for the community members.
Thank you, Ms. Wood. Ms. Yakalai, do you have a question?
Yes, I do. Thank you, Mr. Chair, and thank you for the presentation. For graduates that are graduated, how many have registered for with CAN in the last year? Thank you.
Ms. Wood?
Thank you. Thank you for your question. I would need to go back and confirm those details with our registration team. We don't have them on hand at this moment, but we would be happy to provide an informed response. I can say with confidence that it is the majority of our graduates, but we could provide a more fulsome answer at another time if that works.
Thank you, Ms. Wood. Ms. Yakalai, do you have a follow-up?
Yes, I do. And how long does it take out of territory or INS to get registered in the NWT, and how long before they end up in a community? Thank you.
Thank you, Ms. Yakalai. Ms. Wood?
Thank you for your question. So in general, once all the information is received for a nurse to move to the Northwest Territories and to seek licensure, it takes us on average 1.29 business days to actually complete their application. That said, that does not address how long it takes for us to receive information from other jurisdictions that's required for licensure. And we also can't speak to how long it takes for the employer to get those nurses into the community and practicing. Thank you.
Thank you, Ms. Wood. We'll go on to our second round. Mr. Testart?
Yes, thank you. I'm just wondering if you get in your survey, sorry, let me rephrase that correctly, Mr. Chair. If the survey that was completed by CAN and just their ongoing engagement with the profession, has there been suggestions made from nurses on how we can improve the regulatory system? I know many of those have been put into place. We've heard about some of these initiatives, and I really commend CAN for stepping up and just doing it so we can address some of these issues. But is there anything that is required at a territorial level that CAN can recommend to this committee on improvements, whether it's to the nursing professions legislation or the Health Act or whatever? But if there's areas we can look into as a committee on the territorial policy environment, I would be interested to know what those are. Thank you, Mr. Chair.
Thank you, Mr. Testart. Ms. Wood?
Thank you for the question. I think a lot of the work doesn't just lie at a territorial level. It really lies at a national level and figuring out how we can improve labor mobility of the nursing profession. I think in terms of territorial, we have implemented a new software for registration, and that has come with some technical hiccups, I will be honest. And so that is an area of improvement that we are hoping to work on over the next year. I think that as well, when it comes to registered nurse and RPN authorized prescribers, we have some area around policy development and improvement that can be undertaken that would further implement how those professions are integrated into the health workforce. From a regulatory perspective, I think that there's always room for improvement, particularly in terms of right touch regulation. We, as the regulatory body, have to make sure that we are empathetic and that we ensure that our registrants are heard, but also that the public is heard and has a place to go to address their concerns. Thank you for the question.
Thank you, Ms. Wood. Mr. Testart, do you have a follow-up?
Yes, thank you. And yeah, I appreciate that this is a national issue, especially around labor mobility. The nurses, I think, is the program that is going to help with that effort. When is the expected implementation date for that again? And are there any challenges to that implementation that could be a risk to ensuring they gets out there quick enough to start making a difference? Because again, we're not competitive with labor markets across Canada, then we will continue to suffer from this nursing shortage, and much more acutely than perhaps down south where they have more options. Thank you.
Thank you, Mr. Testart. Ms. Wood?
Thank you. Nurses, we are hoping to have implemented by end of January, early February at the latest. I would say that there are going to be challenges. While this is an across Canada initiative, we've had 2 jurisdictions that have opted not to be involved, and that is Alberta and Quebec. I bring that up because I think Alberta is where a lot of our labor mobility flows when it comes to healthcare, and so not having that jurisdiction participate in this project does cause some risk to us. One of the most positive pieces about nurses is that we each will have a unique identifier, and I say we because I, as a nurse, will have a number, and that would follow me from every single province and territory. But without Alberta being involved in that, we do have to run the additional verifications and the checks to make sure that that nurse is operating and practicing safely in that jurisdiction where a lot of our workforce comes from. That can cause delays. Thank you.
Thank you, Ms. Wood. We'll go on to Emily Morgan. Do you have a question?
Yes, thank you, Mr. Chair. So one of the recommendations you made in your presentation around allied health professionals was to advance the ability of those professions to self-regulate in the territory. And I guess the default of what's happening otherwise is that either the employer ends up sort of acting as a regulator, or they might be licensed in another jurisdiction, but it's really hard to have that oversight when their licensing body is so far away. However, many of those groups would be relatively small compared to the size of the amount of nurses practicing in the territory. So in terms of what would be possible for regulation or self-regulation of allied health professionals in the territory, I mean, do you happen to know if it's viable to have regulation of a group of professionals that, might be less than 100 people in the territory? Or do you know if there's any models of that are sort of hybrid in terms of self-regulation, but maybe they collaborate with another body in the territory or another licensing or regulating body elsewhere in the country? Are there ways we can overcome this to make it better than it is now, but maybe it won't look the exact same as it does in somewhere like Alberta, where there's a much larger body of professionals? Thank you, Mr. Chair.
Thank you, Ms. Morgan. Ms. Wood?
Thank you for your question, and it's a really great question, and there's some very interesting models happening around allied health regulation in other jurisdictions. Right now, I would encourage this committee to look to British Columbia's Health Professions and Occupations Act. And so within that, they've recognized that they have many allied health professions and other regulated professions that require oversight. But rather than having that direct government oversight and regulation, which does cause a bit of a conflict of interest being the primary employer and being the regulator, they have gone with this HPOA oversight in which they have an arm's length regulator that encompasses all allied health professions. And so that builds them their strength in numbers, and it provides them with specialists in each of these areas while also delivering regulatory oversight. Thank you.
Thank you, Ms. Wood. Do you have a follow-up, Ms. Morgan?
Thank you, Mr. Chair. I wanted to ask about a different topic you brought up around registered psychiatric nurses. So it was not on my radar that we had so few. We only have 5 registered psychiatric nurses being used in the territories. And it seems, according to your numbers, if you're saying that there's 40 employed in NWT and Nunavut and only 5 in NWT, I'm assuming there's many more, like 35 or so, being used in Nunavut. Do you have any explanation of why the NWT in particular has so few registered psychiatric nurses right now, or what about how our system is designed? Like, does it intentionally exclude them, or we're just not attracting them? Or like, can you explain a bit more about how we got to the current situation? Thank you, Mr. Chair.
Thank you, Ms. Morgan. Ms. Wood?
Thank you. The government of Nunavut has worked very hard to have a very fulsome mental wellness and addictions recovery model, and within that they have integrated significant volumes of RPNs into their mental health settings, and not just their mental health settings, but really their community healthcare settings as well. So many communities have a registered nurse and a registered psychiatric nurse. And so again, going back to that team-based care model, they're ensuring that they have a wide variety of supports for their communities. In the NWT, I don't believe that we are recruiting for registered psychiatric nurses specifically. What I have seen is that there are often job descriptions that are for mental health settings that will allow for a registered nurse or a registered psychiatric nurse, but it's not explicit to the RPN profession, where Nunavut is specifically targeting this designation of nurses.
Thank you, Ms. Wood. I don't see any further. We'll go to a third round if time permits. Anybody has? Mr. Testart, go ahead.
Yes, thank you, Mr. Chair. I'm just wondering if the IEN issue, this committee's received a presentation from the government on their work on this file, and we know that CAN has really made a lot of progress here. My understanding is when it comes to working or kind of identifying IENs from jurisdictions with comparable standards of care, or I don't even know how to put it, like favored professional environments, like the UK, the United States, Australia, New Zealand, and that they will fast track, or sorry, that some jurisdictions will go into this fast tracking process. I understand Nunavut is ahead on this work. Can the CEO speak to that work in its jurisdiction and the lessons we might learn in the Northwest Territories? Thank you.
Thank you, Mr. Testart. Ms. Wood?
Thank you. I did take the liberty of pulling a bit of a jurisdictional scan around what other jurisdictions are doing for IEN licensure. And I think this is a prime opportunity to outline that every single jurisdiction is operating a little bit differently, but we are all operating under the fact that we need to look at not just the nurse, but the education that they've received and then what the practice has looked like. And so we are currently looking at collating the evidence around countries such as Australia, Ireland, New Zealand, the UK, and seeing what their programs look like in terms of nursing. One of the gaps that we're seeing is obstetrics. And so we can be creative in how we approach that, and we see with other jurisdictions that they're also taking a similar approach. So if obstetrics, for example, is missing from that nursing education, then we can have nurses that work in other settings. just don't work in the obstetric setting, there's a way to provide that oversight and care delivery. And we also are considering that in other jurisdictions, they have transition to practice courses for internationally educated nurses. And so in Ontario, rather than completing the Inspire assessment, they determine if the education is equivalent, and if it is, and they have practiced within X amount of years, they take a transition to practice course, which has 400 hours of clinical experience, and then they're able to practice in the jurisdiction. So if we could provide and support that kind of care delivery and support for internationally educated nurses, we could increase the volume.
Thank you, Ms. Wood. Mr. Tester, do you have a follow-up?
Yes, thank you, Mr. Chair. On the Inspire assessment, what's the cost to the IEN to be assessed? And is that potentially a barrier to accessing the program, given that there's a relatively small amount of applicants that are offside with the expectations? Thank you.
Thank you, Mr. Tester. Ms. Wood?
Thank you. The cost of the Inspire assessment is $2,300, and that cost is set by CAN, and that is because we need to consider not just the cost of our contract with Inspire Assessment Services, but the time and resources that it takes for us to individually go through every single application, take it to the registration committee, and the administrative work that comes after the fact for licensure. That does include the license cost after they've completed the assessment if they're successful in the process. Other jurisdictions have supported nurses with this cost. BC government does provide funding for nurses that want to undertake the process, and the government of Nunavut is also working on how they will fund nurses to complete the Inspire assessment should they need it.
Okay. Thank you, Ms. Wood. Ms. Morgan, do you have a question?
Thank you, Mr. Chair. I wonder if you could speak a bit more to, so you gave us the news that there's going to be a new nursing association of the Northwest Territories. I assume it's not NBT and Nunavut, but just Northwest Territories, starting up in January. Can you explain a bit more? You said that they will have 2 years of funding through CAN, but sort of what happens after that? Or I assume maybe once they get up and running, they'll start sort of some kind of strategic planning process. But I wonder if you can just give us a bit more details about how that, the role of that sort of body within sort of the network or the system, and about funding. What's going to happen after 2 years? What's the plan there? Thank you, Mr. Chair.
Thank you, Ms. Morgan. Ms. Wood?
Thank you. So the NTNAN is actually going to be both Northwest Territories and Nunavut Association of Nurses. And that's an important distinction because we wanted to ensure that as the regulator of both jurisdictions, nurses had a voice in both jurisdictions as well, and which is why we've really pushed to fund this new association for a 2-year period. The association model is a voluntary model in all other jurisdictions, and that means that nurses have to decide to voluntarily provide payment to the association. NTNAN will have to work towards determining what their revenue streams are going to be after this 2-year period. Some ways that they can do that is through looking for government funding. They can approach CAN, of course, for funding as well, and fundraising. So really proving to nurses of the Northwest Territories and Nunavut that it is worth nurses' investment, that they are speaking for them, that they're representing them appropriately in communities, will secure the revenue that they require to operate.
Thank you, Ms. Wood. Do you have a follow-up, Ms. Morgan?
Thank you, Mr. Chair. Not right at the second. Good,
Okay,
thank you.
thank you. Mr. Testart, Ms. Whalen Armstrong, do you have any questions? Okay. Seeing no further questions, this brings briefing to a close. Before we close, Ms. Wood, do you have any closing remarks or final thoughts to share with committee?
Thank you for having us here today and for keeping nursing at the forefront of the decisions that you make. As a nurse and as the person that's regulating nursing or the organization that's regulating nursing, I'm very passionate to see how this profession can continue to grow and to contribute to the healthcare of the folks of the Northwest Territories and Nunavut. So thank you again.
Okay, thank you very much for appearing today. This concludes the public portion of the meeting, colleagues. I'll just ask you to stay as we go into camera to debrief and discuss some other business today. Thank you very much.